I had updated this lecture and I put it on this little stick drive, which is what the directions in the email said to me yesterday. And it fell out of my pocket somewhere. My stick drive is gone. So this, fortunately, was I sent myself on email a couple years ago, so it's a couple years old. Interestingly, pregnant physiology science hasn't changed that much in the last couple of years. So I think we're going to be all right. Now, the other problem is that this is very dry stuff. So I'm going to try to bring it to life for you. Thank you, Bob Pricey. Let's start with. Okay, so pregnancy. I guess I'm supposed to stay in front of the computer. Pregnancy is an interesting physiologic state because almost every physiologic parameter is deranged that you can measure. And there are hormonal changes that occur, there are mechanical changes that occur, and there are metabolic changes that occur. And so I'll try to sort of talk about those as we go through. But in terms of the hormonal changes that occur, these are the hormones that are present in. Actually, I probably should have put endorphins up here as well. Endorphins are present in excess amount. Are they? I did put endorphins. Oh gosh, darn. Great minds. Okay, so these hormones have some interesting effects that have direct ramifications on your ability to care for these patients, and we'll get into that. Just always interesting when you look at the umbilicus, when the fundal height is about the level of the umbilicus is when you have to start thinking about cable compression. One thing that anesthesiologists have to think about a lot is the fact that as the fetal placental, the utero-fetal placental unit grows, at some point you are going to get enough mass that you can get cable compression. And I remember like 10 years ago I was working in the general OR and they brought in this general surgeon, this woman who was supposed to be an expert in surgery for pregnant patients. Patients need appendectomies, things like this. So I think I was taking care of a patient who needed an appendectomy. It was second trimester. And I tilted her. We were about to start the operation. I tilted her to the left, tilted the whole table. And the surgeon's like, "What are you doing?" And I was like, "Wait a second, I thought you were supposed to be an expert and take care of these patients. She's 26 weeks, right? We've got to tilt her." So about 20 weeks of gestational size is when you have to start thinking about cable compression. Obviously, the heart, like any pump, less goes in, less comes out. The placenta is a fascinating organ, however, cannot autoregulate. Unlike your kidneys, unlike your brain, it's a low resistance shunt. It's going to get 10% of the cardiac output. That's what it's going to get. No autoregulation. So you got to maintain the hemodynamic parameters in your patients. Cable compression is something that can sometimes be concealed. In other words, you could measure the blood pressure on the arm and look at the patient. She doesn't look ashen gray and diaphoretic. However, there is certainly some cable compression going on, and maybe even some aortal compression that is going to have effects downstream to the baby. And in terms of the cable compression, you're going to be utilizing a lot of azygous system, perivertebral venous return, and so some patients though have revealed cable compression. And interestingly, those patients tend to be folks who in general don't have the crisp autonomic reflexes that you guys have. So for example, one day on my case list when I showed up to OB, there was an elective C-section on a 56-year-old woman. Now normally, since I'm approaching, I'm getting close, I'm closing in on that number. That would seem to me to be the young patient to be taken care of in the general OR. But when you're over on doing a C-section, that's a different story. And this patient, when she laid down flat, and granted, I think she had some diabetes, so she had a little bit of macrosomia. She became ashen gray and diaphoretic. So it actually, when we put her spinal in to start a C-section, she nearly coded on me. So that was not fun at all. But You have to think about cable compression. About fundal height, the level of the umbilicus is when you need to start thinking about it. And actually, in the latest guidelines, 2010 guidelines that came out in fall from AHA in terms of CPR in a pregnant patient, they changed the wording slightly. They used to say in the 2005 guidelines, they said 20 weeks gestation or greater. You had to tilt the patient. Now they say 20 weeks gestational size. So obviously some people might have bigger babies than 20 weeks than others. So interesting. I don't think they would try to get you on a board's question on that, but I just thought that was kind of. The two systems I really want to go over today are pulmonary and cardiac, although there are widespread changes in the central nervous system, renal. I mean, there's all over. But the respiratory and the cardiac, what the bulk of the questions on the boards are, and I think again, this is a couple years old, but I think I embedded some of those questions in here. So we'll see. I'm not sure I'll be able to get the answer, so hopefully we can all get it. So you will read literature that suggests that you need to be very, very scared of doing general anesthesia on a pregnant patient. That data is to be taken to heart. Certainly, we know that the plasma oncotic pressure during pregnancy decreases, and we know that people get edema, sometimes dependent edema, sometimes not dependent edema. This particular patient who I was caring for 10 years ago, when I went to intubate her, her epiglottis was this thick. I mean, it was literally, just oropharyngeal laryngeal edema. It was unbelievable. So plasma oncotic pressure goes down, so we know they can get edema, and we know that estrogen is sort of a mitogenic hormone, and it promotes angiogenesis. The mucosa becomes very friable. You do a direct laryngoscopy, all of a sudden you've got blood in the oropharynx. Not every time, but it's something you have to be cognizant of. We know that the lower esophageal sphincter tone is decreased during pregnancy. We know that the placenta actually secretes gastrin, which really creates a very acidic milieu in the stomach. We know that the stomach volume is increased relative to non-pregnant patients. Morgan's shaking her head. We went over this. I think we went over a lecture on general anesthesia this a few weeks ago, didn't we? And so these create conditions that can result in higher rates of aspiration injury. And we also know that intubation can be more technical because of that edema, because of weight gain associated with pregnancy, because the basal metabolic demand is increased. There's mom and fetal metabolic demand, and because the FRC is decreased, so there's less of a reserve tank, if you will. So if you weren't able to intubate somebody, you would probably try to mass ventilate. Well, someone has sort of a gravid uterus, and they gained weight, and they are a little bit swollen. It's more difficult to mass ventilate. So certainly we need to have respect for intubation, or the prospect of intubating a pregnant patient. Having said that, when you look at the data, a lot of the data is from the UK, because the Brits are very good about keeping data. I mean, they have the longest running, I think, repository of information on pregnant patients in the world. It started in the 50s. It's called, well, now they changed the name. It used to be called Why Mothers Die. That was the name of the report. That was not a very good name. So they changed it to Saving Mothers' Lives. Glass half empty, glass half full. It comes out every triennium, or it's a triennial report. But when you look at that data, it suggests, and when some of the Brits in the UK have done retrospective analyses, it suggests that the rate of difficult intubation in the pregnant population is 8 to 10 times higher than in the non-pregnant population. So that's something we need to respect. However, it's a little bit confounded, that data, because in the UK, if you ask Brendan or Alex or all these guys who trained over there, Jeremy, a lot of times trainees are taking call in-house without attending backup that's in the hospital. And so, yes, this 1 in 250 difficult airway numbers is the thing that sticks in our craw when we think about intubating pregnant patients. However, that's probably confounded because that could incorporate data from people who were taking call for the first time or very, very inexperienced on the ward doing general anesthesia by themselves for an emergent time pressure situation. So you can imagine how that could confound the data. One thing I wouldn't do in a pregnant patient is put in a nasal temp probe. Patients often have epistaxis as it is. That mucosa, again, is very friable. That's something that I would avoid. That's a little clinical pearl. That'd be a bad call. Here's a board's question. Fantastic. Which of the following lung volumes or capacities change the least during pregnancy? So that's tidal volume, functional residual capacity, expiratory reserve volume, residual volume, and vital capacity. Let me take it if I remember the answer. Yes, I do. Okay. Does anybody want to take a guess? I don't expect you to know that. Michael. Did you say BC? If I had chocolate, I'd give it to you. You want a cookie? Cookie? Yeah, that's actually correct. So let's go through these. The tidal volume actually, let me make sure I've got my numbers correct. Tidal volume increases by 40%. I believe I have that on a slide later on the top. The functional residual capacity, I believe, goes down by 20%. I think the slide following this. Why am I guessing? I think it goes down by 20%. So let's take a look. Yeah, FRC decreased 20%. All right, so you can see the vital capacity, no change. Inspiratory capacity is increased slightly. The expiratory reserve volume and the residual volume, remember, are what comprise your FRC. So as a demonstration, just to make sure we're all sharing the same mental model, I'm taking tidal volume breaths right now. This is my expiratory reserve volume. And what's left is my residual volume. Those two things comprise my FRC. Okay, and that's an important thing, because I'm sure you guys have seen, or if you haven't seen it yet, if we work together, we can try it. You can pre-oxygenate someone really, really well. And if you do a really good job, let's just break this down number-wise. Let's say somebody has a functional residual capacity of 2.5 liters, an average size person. And you completely denitrogenate. When you do a 10-minute, you do a superb pre-oxygenation. And you've got 2.5 liters of not 21% oxygen, but 100%, 1.0 fraction of inspired oxygen in that 2.5 liter tank. Now, how much oxygen do we use at rest per kilo per minute? Does anybody remember? Anybody know? Yeah. Let's just say it's 3 just to make it easy. 70 kilo patient or 75 kilo patient, 3. So that's about somewhere between 200 and 250 cc's of oxygen a minute they're using at rest. For any athletes out there, anybody know what the other end of the spectrum is in terms of these elite athletes like Lance Armstrong or those guys? That number is actually called the VO2 max. You may have heard of that. But so at rest, humans use about 3 cc's of oxygen per kilo per minute. What is it on the other end? Anybody know? I think Lance Armstrong, so they say a fit male will be about 40. Lance Armstrong, I think, was in the 80s. Greg LeMond, I think, was actually in the low 90s. And there was a Swedish cross-country skier who I believe had over 100 cc per kilo per minute VO2 max. So that's an interesting, that's quite a range, isn't it? It's a 30-fold increase from 3 cc's at rest to 90 plus. At any rate, if you pre-oxygenate someone really effectively, they're going to be able to go for nearly 9-10 minutes without desaturating.
Your pace not be fitness.
Lower
oxygen consumption.
Oh, I never thought of it like that. So, well, the VO2 max is, I mean, obviously how much you train, but also how big of a heart and lungs are you born with. I mean, these things are, a lot of that's genetically predetermined. But it's interesting that you could actually have somebody, they'd get hypercarbic. How quickly do they get hypercarbic? Anybody remember? How many millimeters of mercury each minute does there with somebody's PaCO2 change? I ask you this because we had an M&M here a couple years ago, a patient under MAC anesthesia, and they weren't measuring they didn't have one of those nasal cannula that had the little port off of it that you could do capnography. And turned on the propofol, and there they went. And they started having some PVCs, and there was some cardiovascular collapse. Anyway, they did a blood gas, and I think it was the PaCO2 was in the 90s. How long would it take to get from 40, which is normal, to 90, which is abnormal? Anybody know? How much do you change the first minute?
Like 4 or 5.
Yeah.
And then 3.
Yeah. So you can calculate the minutes. That was a long time that patient was apnea. But you can see that if someone is well oxygenated, so the key there is monitor. Capnography is very important. Monitor that. Okay, so here's some of the numbers. I don't know that you'd ever get tested on the boards on these, but I think they're good numbers for you to know. As anesthesiologists, you are sort of experts in pulmonary and cardiac physiology and pharmacology. So you can see the vital capacity there. Michael told us there was no change. It's about 4.5 liters. And so that's basically this maneuver. So when you pre-oxygenate patients, do they do that? No, they don't. It might take deep breaths for you. They might take inspiratory capacity breaths, but then they do passive exhalation. So what's the problem with that? They're not doing vital capacity breaths. You read the books and they'll say 3 vital capacity breaths or 4 vital capacity breaths. Go talk to Dr. Saban. He'll break it down for you in the formula. He'll show you that's all you need. And I agree, that's true when you look at the formula. But he's much smarter than me. So whatever he says, I'd listen to it. However, I would just propose, and I think Dr. Dooley and I discussed this during that talk, that what I just did, if my vital capacity is 4.5 liters, and you just saw me do it, it took about less than 5 seconds to do that. So that means that in the course of a minute, I can do that about 12 times, maybe more. And that was 4.5 liters. Let's just make the math simple. 5 times 12, 60. I'm pulling a flow rate of 60 liters a minute. What's the maximum flow rate on the machine that you can give me? That oxygen flow meter, remember? Yeah, 15. Some machines actually max out at 10. So what happens when I'm pulling 60 liters a minute and the machine is giving 15? Yeah, you're probably getting some rebreathing and some entrainment of room air. So I think 3 vital capacity breaths, 4 vital capacity breaths, 5 is better than nothing. But they often don't do vital capacity breaths. They take deep breaths and have passive exhalation, and they're pulling more air than the machine can keep up with. So it pays if you had more time to pre-oxygenate a little bit longer. I cannot tell you the amount of safety you confer prior to the start of a general anesthetic by really doing a good pre-oxygenation and a good ramp. Those 2 things, you take anything from this lecture, those are 2 really good things to do. By ramp, I mean tragus, probably the level of the sternum when you have them ramped up. Improves your mechanics of respiration, might make it easier for you to mass ventilate if you couldn't intubate. Okay, and total lung capacity is nearly 6 liters. So, here's we have this graphically. So, what we have, non-pregnant on the left and pregnant on the right. So you can see the diaphragm gets pushed up a little bit by baby. So the total lung capacity gets negatively affected by a little tiny bit. But the vital capacity stays the same. But you can see where that's coming out of is essentially the FRC. So the FRC is decreased. Oh dear, there's nothing on that slide. Let's see. Okay. So our patients breathe more frequently and take deeper breaths. Why do you think that would be from a teleologic orientation. Why would preggers patients take deeper breaths and breathe more frequently than a non-pregnant patient? Yeah. So, and there's some luxury minute ventilation built in there. But if I took your PaO2s right now, and we could break the formula out, but if I remember correctly, you guys should be somewhere in the 90s. And certainly when you're working in the ICU, you're happy to extubate people when their PaO2s are even perhaps a little tiny bit lower. Remember the 30, 60, 60, 90 rule? If you guys heard that one, if your PaO2 is 30, your oxygen saturation will probably be around 60. Your PaO2 is 60, your oxygen saturation is going to probably be around 90. So once you get over PaO2 of 60, your sats are in the 90s. You don't have to wait for somebody's PaO2 to be in the 90s. But pregnant patients, their PaO2s are higher. Usually 103 to 105. And it's as a result of that increased minute ventilation. Why is that? Some people think, but nobody really knows. If progesterone, they think, has something to do with it. That's not something I think you get a boards question on, but it's kind of fascinating. This is one of the, I told you there was hormonal, mechanical, and metabolic changes that occur with pregnancy. This is one of the hormonal changes. Tidal volume increases 40%. Respirations only increase about 15%. But look, by the 7th week of pregnancy, the minute ventilation has increased by a third. A lot of people don't even know they're pregnant at the 7th week of pregnancy. That's a lot of increase. It's a lot of increase. Interestingly, our patients that have asthma tend to tell us, Doc, my asthma's seems like it's been okay. Unless they're having really severe reflux, which is a different story. Now, I wrote here chest wall, not lung compliance decreases, but returns to normal after delivery. The difference between chest compliance and lung compliance. So, there is nothing about the lung parenchyma of a healthy young woman that should be negatively affected by the pregnant state, unless she's preeclamptic on magnesium, goes into pulmonary edema. Normally the lung parenchyma should be normal. But certainly the chest wall compliance decreases, and that's why I was talking about earlier. Mass ventilation can be more problematic. And when you look at chest x-rays of pregnant patients, the AP diameter of the chest is increased. So if I take my rib cage and I pull it out to here and now breathe my tidal volumes, and remember, their tidal volumes are increased by 40%, I'm feeling some resistance on my chest wall. So I think one of the take-home lessons from this slide is, God forbid you were ever in a situation where you were doing a general anesthetic on a pregnant patient and you could not intubate, could not ventilate. You tried all your maneuvers, you tried an LMA, you called for help, you tried two-handed mask, nothing was working. I think at that point, although the textbooks would say wait for the propofol and the succinylcholine to wear off. I mean, if my hand is forced and the oxygen saturation is in the 50s and the patient's not waking up and I can't ventilate, I think at that point I tell the obstetrician, you go ahead and get the baby out. Number one, now at least we have one patient that can start to be resuscitated by the neonatologist. But number two, that chest wall compliance goes immediately back to normal. Now maybe I can squeak some air in with two-handed mask ventilation. So hopefully you're never in that situation. But that's kind of the second point of this slide here. Okay, so the oxyhemoglobin dissociation curve, it's right shifted during pregnancy. What are other things that right shift the oxyhemoglobin dissociation curve? Anybody? Sure. Anything else? Temperature. In other words, the hotter They are with shift to the right, right? And what else? Yep, yep. So it seems like the things you're telling me are things which are associated with sort of hypermetabolic, higher metabolic processes. And what happens when you shift the curve to the right in terms of the ability of, how can I phrase this question? Is it easier for hemoglobin molecules to give away oxygen, or less easy to give the oxygen molecules away when the curve is right shifted relative to when it's normal? More easy. So this is a beautiful design, isn't it? You got a mom's P50, our P50. Everybody in this room is pretty much probably right around 26, 27, I would guess. And you're going to right shift the mom to 30. So the fetal hemoglobin, anybody know what the P50 is? The fetal hemoglobin is? Yeah, I read 19, but yeah, it's less, somewhere right around there. So what a beautiful design. That's a nice gradient to drive that oxygen down to the baby. As an aside, what happens when patients come in for labor and they have a contraction and they hyperventilate? What does that do to the curve? Respiratory alkalosis, what would that do to left shift it? So people who are really pro-epidural, I read a little like a editorial once, and they were saying epidurals help optimize the oxygenation of the baby. And I was like, what? And the rationale that this particular writer was using was saying that by mitigating some of that pain and mitigating that hyperventilation, that you don't get as much of a left shift and you maintain that gradient. I thought that was a little far-fetched, but it helped me remember. Interesting system, and you will get tested on the boards about that. P50 goes from 26, 27 to 30 in the pregnant state. Which of these respiratory parameters is not increased in the parturient? That's a fancy way of saying the pregnant patient. Parturient is pregnant patient. So minute ventilation, tidal volume, arterial PO2. I already gave that one away. O2 consumption, and serum bicarbonate. Bicarb, good call. So let's let me see what's coming up on the next slide. Yeah, so if I did an ABG on every single person in this room, what page is coming through?
It's for OB.
It's for OB?
Yeah, we have the pages. So they would get on par with exactly.
Oh, okay. 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 So, gosh. So, if I took the PaCO2 from a blood gas in every single person in this room right now, the PaCO2 would be 40. I mean, it's so, you are so sensitized to PaCO2. If you've swum underwater and you're feeling that very uncomfortable feeling where you want to take a very deep breath, that's not hypoxia. That's hypercarbia. I've always thought it's ridiculous. You ever seen a football game? These guys come to the sideline and put the oxygen mask on. Number one, none of it's getting to them. But number two, they're not hypoxic. So, I mean, it's ludicrous. So, the PaCO2, there was a study where they put folks under general anesthesia and they had them spontaneously ventilating. And then they increased the PaCO2 from 40 to 41. They increased their minute ventilation by a minute and a half, by a liter and a half per minute. We are extremely sensitive to change in PaCO2. Now, these patients, their PaCO2 is 30 to 32. That is a marked change. 40 down to 30 to 32. That's impressive. And that's by 12 weeks gestation. The way I remember this is not causal. I'm just saying the way I remember this is that my sister, a lot of people I know who've been pregnant say they really have this feeling of breathlessness. And it's kind of uncomfortable almost. And my way that I remember it is that I always wonder is, as that threshold, as that set point is changing and climbing down from a PaCO2 to 40, 39, 36, 34, down to 30, 32, is there a relative feeling of hypercarbia being perceived by that pregnant woman? Now, I don't know, but that's how I kind of remember this. But it is a massive change. So what happens is, you guys answered the question. You said bicarbonate was the answer. So these patients have a respiratory alkalosis. So if I took your pH and I measured it, it'd be 7.4. And your PaCO2 would be 40. So if I take you from 40 down to 30, what's going to happen acutely to your pH? What number would it be? Anybody know the number? It's supposed to be 0.08 for every 10. Boris nailed it. So it should be 7.48 if you go from 40 down to 30 acutely. But that's not what our patients have. They have 7.44. So what does that mean? That means they have metabolically compensated. They've wasted some bicarb. And so, interestingly, they don't have as much buffering capacity as the rest of us. They get acidotic a little more easily, sort of like a really long labor or something like that. I've also seen boards questions on that. It's kind of interesting physiology. So whatever, I just said it right here. Metabolic acidosis occurs more readily. Especially from prolonged labors, as a result, there's increased bicarbonate buffering capacity. Okay, so you can then take that 30 PaCO2 and drive it down to 20 during a normal labor as patients have contraction. That to me is just crazy. Yeah, if you can, that normal in us is 40, that you can get down to 20. Okay, so oxygen consumption obviously increases during pregnancy. The biggest increase is during labor when somebody's really working hard. But again, the minute ventilation is increased during pregnancy, and so I think there's actually sort of some luxury built into that because the PO2's up. And again, like you guys said, it's because you have a growing fetus, which is has its own basal metabolic requirement for oxygen. This was a board's question, and so I looked it up because I just couldn't believe that they were asking it. But and it was from references from the 60s, and this was like not that long ago. So they asked in this board's question, if you gave a spinal to a patient to a T4 level for a C-section, would it alter the resting PaCO2 or the minute ventilation? And the answer was no, but obviously it decreases the FRC, decreases the coughing force. So we used to, so the side note on this slide is that we used to, for right before we started a C-section, we would give everybody 30 cc's of Bicitra, which if you've ever had Bicitra, it tastes disgusting. Okay, she likes it. Esty likes it. It's like a sweet tart. It is kind of like a sweet tart. We had butterscotch flavor for a while, and that was disgusting. That was really disgusting. And it makes some people throw up. And so we start scratching our heads going, These are patients that have higher volume in their stomachs, lower pH, lower esophageal sphincter tone. We're lying them flat. We're giving them a block up to T4 and taking away some of their coughing force, and we're giving them Bicitra, which might make them throw up. So we stopped doing it. Except if we knew we were heading down the pathway to general anesthesia. Then we do it. But not routinely when we're using regional. So anyway, I thought that was an interesting board's question to ask. I couldn't believe it, actually. All right, so any questions about pulmonary stuff before we get into cardiovascular? How are we doing on time? What time does that clock say?
25.
Is it 25? Oh dear. All right, well, we're not going to get through cardiovascular. Let me just make sure there's no really critical points. Okay, so one board's question I've seen is about EKG changes. So, what is the normal axis for electrical energy through your heart? Is it like this? Is it like that? Or is it like that? Okay, very good. So what happens when you have a really tall, lanky person? It can get right shifted. What happens when you have a morbidly obese person or a pregnant patient? It can get left shifted. So that I've seen that as a board's question. It can be normal to have a little bit of left, axis deviation to the left on the EKG in a pregnant patient. Let me just make sure there's not anything else really critical. So this is important. Near term, 35 to 40% expansion of total blood volume. That's, again, a very interesting design. 300 to 500 cc's of blood loss is normal with a vaginal delivery. 800 to 1,000 is normal with a C-section. Because you just told you that the blood volume is increased by 1 liter to 1.5 liters. Perfect. The plasma volume increase exceeds that of the red cell mass increase, even though you get erythropoietin increases. In pregnant patients, the red cell mass can't keep up, so you get a dilutional anemia of pregnancy. I see patients with hematocrits at 34, 35 all the time. I think 33 or lower, I would start thinking of a microcytic, anemia. I'd say ask somebody if they were taking iron, but these are important numbers to just have seen once or twice. We can skip this slide. We can skip this slide. This is kind of an important concept. So, the gravid uterus, every time it contracts, it's engorged with blood, and then when it contracts, it kind of gives you an autotransfusion. So it's like increasing your preload with 300 to 500 cc's of colloid every time you get a contraction. And then, of course, after the baby's delivered, hopefully you get good uterine involution. Sometimes you don't. You have apnea. But hopefully you do, and that's kind of like a 500 cc autotransfusion, and you decrease the vascular space by the same amount. The non-pregnant blood volume is reached a week to 2 weeks after delivery, and I've seen that on board's questions too. Blood volume goes back to normal within 7 to 14 days. Erythropoietin, I've seen a question on erythropoietin, and it rises by 8 weeks of gestation. Again, a lot of patients don't even know they're pregnant by 8 weeks. But it cannot keep up with the plasma increase. Cardiac output returns to non-pregnant levels by how many weeks postpartum? Anybody want to hazard a guess? I heard. What did you say? B? Yeah, good guess. It actually is in parallel with the blood volume decrease. Pregnant patients' heart rates are slightly elevated over normal. Normal is somewhere around 84. Normal for non-pregnant patients somewhere around 72 or so. The stroke volume also increases from somewhere in the 70s, which is normal for most of us, to actually in the 80s. So, whereas our cardiac outputs are something like 72 times, 76 or whatever, somewhere around 5 liters. Pregnant patients are more like 6, 6.5, 7 liters. So that answers that question that you just answered correctly. It declines to non-pregnant levels by 2 weeks after delivery, but it increases 8 to 10 at 8 to 10 weeks. This was a crazy guy. This guy Clark, he somehow convinced pregnant patients to let him float Swan-Ganz catheters in them. I'm not sure how he did that. Early data obtained in the supine position showed a decline in the cardiac output between 28 and 32 weeks. They weren't left tilting the patients. So once they started doing that, they didn't see a decline in the cardiac output. But you can see heart rate increased 17%, stroke volume 18%, cardiac output increased 43% in pregnancy, SBR decreased, and pulmonary vascular resistance decreased as well. We talked earlier about how progesterone is a good bronchodilator. This is not important stuff to know. Okay, here's another question. You don't have K-types anymore. I don't know if you guys are familiar with this. A K-type, well, we'll just go through them. I'm not going to waste your time. Adverse effects associated with compression of the aorta by the gravid uterus include, just tell me which ones you think are pertinent. They're asking about aortal compression. Four. You guys are wicked smart. I always trick people on this every time. Yeah, so cable compression would give you 1, 2, and 3. Aortal compression is going to give you 4. Well, I guess frankly, cable compression could indirectly down the road give you 4 as well. But that's what this question was trying to get at. In supine position, the term cardiac output decreases 30-50%. I become viscerally uncomfortable when I see a pregnant patient laying flat in the bed. I just get nervous. I ask, can you just tilt one direction for me a little bit? So here I was talking earlier. Paravertebral epidural veins can empty into the azygos system for alternative return routes. Even with normal upper extremity BP, the uteroplacental perfusion may decrease when supine. This is all studies that were done in the 60s. So they recommend a left tilt of 15 to 30 degrees. Anybody know how much the leaning tower of Pisa is tilted? I looked it up. It was like 5.7 degrees or something. It's less than you would think. So 15 to 30 degrees tilt is a pretty good tilt. Somebody looked at that leaning tower of Pisa. I thought it was less than 6%. I can't remember. Oh, this is a good slide. Let me see. We got one more minute here. Oh, late. So if you look at the weeks are on the x-axis, and on the y-axis we've got cardiac output changes, stroke, volume, and heart rate. And you can see how basically the heart rate basically increases during pregnancy. The 4 degrees.
It used to be 5.5 until 2000. Now it's 3.99.
Wow. 3.99. 15 to 30 degrees is a lot of tilt. Anyway, you can see here right near right near the end of pregnancy, you can see how the cardiac output is starting to come down a little bit in the supine position. But look, actually it starts to come down here at about the 28-week mark. But look what happens in the lateral position. It's maintained. And the stroke volume, interestingly, is maintained in the lateral dotted line. But if in the supine position, it goes down starting at, looks like, 24, 28 weeks. So start tilting them at 20 weeks. Oh, one last question. I'll let you go. Uterine blood flow at term pregnancy is 50 mils a minute, 250, 700, 1,000, 1,500. I think I kind of gave this away earlier. See, so it's 10%. Yeah, about 700. Yeah, you can see what it looked. The difference in the uterus increases from 70 gram weight to 1,100. You guys are crazy. This is why acne is so devastating. 700 cc's a minute, and if you can't get control in a few minutes, you've already lost 2 liters. So that's why it's a big deal. I'm not gonna. Yeah, we'll skip all that. All right, so we made it through pulmonary and cardiovascular. I know that's dry stuff, but if you want, I can. If you have any questions, you can shoot me an email or whatever. I know you guys gotta run. And so do I. I gotta go to meet. Any burning questions right now? All right, thanks a lot.